Hello. Hello.
Hello.
Hello.
Hi. Are you guys able to hear me properly?
We can hear you.
Okay, that's great. So, can you guys just tell me what are the remaining topics left in our? Okay, let me first of all share my screen. Okay, what are the remaining topics left in the red blood cell module? Can you just please tell me that? Hello. Hello. We did. Okay. Have you finished microcytic anemia, macrocytic, and normal with Dr. Moss? Or do you guys want me to do it again with you guys? What do you guys suggest? I
We
did
did
microcytic.
we did
Mhm.
microcytic and in normocytic we did the first three: hereditary parasitosis, paroxysmal
Okay.
nocturnal hemoglobinuria, and G6PD. We didn't do the rest. And the
Okay.
extrinsic hemolytic anemias are still left, and we just got the overview of macrocytic anemias by you the other day,
Mhm.
but we didn't do that with Dr. Moss either. And I think the rest of it is still left: iron poisoning, heme synthesis, etc.
Okay. So I would suggest it to do it from microcytic, right? And let's go over it. So it's going to be a kind of revision for you guys as well. So let's start it from the beginning because I want you to go through the microcytic, then macrocytic, and in the end macrocytic because it's really confusing, right? If you just started doing, from in random way, right? So we discussed microcytic. If you guys remember, we discussed iron deficiency anemia, right? Okay. Hello.
Yes.
Okay. Okay, let's just start from microcytic again. A quick overview, so so the things should not be mixed. Okay, for a microcytic anemia, we discuss MCV, right? What is MCV? We discuss its mean corpuscular volume. What is corpuscle? The single red blood cell is also known as corpuscle, right? The red blood cell, that biconcave structure, it's also called a corpuscle as well, right? So mean corpuscular volume basically means the amount of volume which is present in a single red blood cell. Mean corpuscular volume. We discussed that whenever we have any problem with hemoglobin formation, the cell is going to undergo an extra division leading to microcytosis, right? We discussed that red blood cell is made up of, mostly it have hemoglobin to carry out oxygen. Okay, we discussed that hemoglobin further is made up of heme and globin, right? Am I right? Hello?
Yes.
Okay. We discussed that heme itself is made up of iron and protoporphyrin, while the globin chains can be beta globin or alpha globin chain. So we discussed if we have problems with iron, if we do not have proper iron, we won't form heme. If we cannot form heme, we cannot form hemoglobin. If we cannot form hemoglobin, the red blood cell is going to undergo an extra division in order to compensate that little amount of hemoglobin that is being made, right? If we do not have proper. Same is the case with protoporphyrin, right? If we have less protoporphyrin, it means we have less heme. If we have less heme, it means we have less hemoglobin. If we have less hemoglobin, the cell again is going to undergo an extra division in order to compensate that decreased amount of hemoglobin, right? Same is the case with the beta globin chains. If we have less beta globin chain, it means we have less hemoglobin. If we have less hemoglobin, it means that cell is going to undergo an extra division. Same is the case with alpha globin chain. So is it clear the concept of microcytic anemia? Whenever we have less content within the red blood cell, your red blood cell is going to undergo an extra division, which is going to lead to microcytic anemia. Is this concept clear? Hello?
Yes.
Perfect. So let's just start with iron deficiency anemia, right? Let me just open my. Okay. So let's discuss iron deficiency anemia. We discussed that iron deficiency can. Okay, just give me a second. We discussed that normally the iron is being reabsorbed where it's being reabsorbed in your, yes, duodenum, right? It's reabsorbed in duodenum, right? Am I right?
Yes, yes.
Okay, duodenum. So we know that, for example, if this is your duodenum, you have a specific, receptor for that. We discussed that was a ferroportin receptor. Remember? Hello. That ferroportin was basically able to reabsorb iron from your lumen and get it into the blood. Once it get into the blood, we discussed we have something called the transporter molecules, transferrin, being made by your liver. So these transferrin are going to catch this iron and they're going to take them into the storage part. Where do we store iron? We store iron
Liver,
in liver and where else?
bone marrow.
Bone marrow, the macrophages of liver and macrophages of bone marrow. And once they are stored, they are called ferritin stores. Ferritin store. So we have transferrin, which transfer these iron molecules to the ferritin, which are the storage part of these iron molecules, ferritin stores, and we store the iron there because if iron is left, alone, so it can form free radicals, which can be very destructive to our body. We are going to discuss that in our one of our pathology, ferritic ataxia, right? Via Fenton reaction, they can just form free radicals and they can damage your body parts. We'll be discussing that, right? But remember, in the ferritin stage, the iron is not harmful. It's not harmful once the iron is present in the ferritin, right? So we discussed that. We also discussed that, for example, whenever the ferritin stores are high, so the transfer in numbers are going to be less. And that's obvious. If we have proper store, then why do we need this transporter to bring extra iron? We do not need them, right? So they have inverse relation, right? The ferritin stores and the transferins basically have inverse relation. Remember that, right? Another thing which we'll be mentioning in our GIT section, this transporter ferroportin, it's not only a transporter. Keep that thing in mind. This transporter also senses the level of iron within the blood. So it also a regulatory kind of, it have a regulatory kind of mechanism as well, right? So whenever the iron is less, then this transporter is going to be activated and it would reabsorb iron into the blood. Remember, so it's a sensor as well, right? It's a sensor for your iron as well. Why am I indicating this? Because whenever the sensing ability of this transporter is lost, whenever the sensing ability of this transporter is lost, if it could not sense the level of iron, it would keep on reabsorbing a lot of iron, which is going to lead to iron overload state, also known as primary hemochromatosis. Is it clear? So in primary hemochromatosis, we have a gene called HFE gene, which encodes for the same transporter. We are going to discuss the entire pathophysiology in our GIT section. But you should be keeping this thing in mind that it's not only a transporter, it's also a sensor for your iron in your blood. Is this concept clear?
Yes, sir.
Okay, perfect, right? So we discussed that we have these ferritin stores. We discussed via Fenton reaction, they can just cause free radicals as well. Okay, let me just go to this other page. It's really important to know this page, right? Right? It's really important. So we discussed that what is TIBC? TIBC is total iron binding capacity. Who bind iron? Transferrin bind iron, right? So it's basically the measure of transferrin molecules. TIBC is the measure of transferrin molecules because TIBC stands for total iron binding capacity, and we know that the iron is binded to your transferrin. So the number of transferrins would give you TIBC. That's so simple, right? Okay, percentage saturation. Just keep one thing in mind. If we have 10 molecules of transferrin at normal body, at normal body functions, right? Like in me and you, we are normal individual. Only 3 among them are going to be, saturated with iron. The other 7 won't be having any iron to transport it to your ferritin stores. Keep that in mind, right? So can I say that the normal percentage saturation of your transferrin molecules are 30 to 33%? Yes,
Yes.
because out of every 10, only 3 are normally bounded, right? So that's basically going to be, your percentage saturation. We are going to discuss these entire things once we just come to lab values, right? And I just told you that ferritin is inversely proportional to your transferrin molecules, and that makes a lot of sense as well. So let's just do it, right? Okay. In which individuals we can have iron deficiency? That's really simple. Infants who are breastfeeding. Why? Because the breast milk do not contain sufficient amount of iron. Children with poor diet, because if they have poor diet, if they are consuming meat, iron rich supplements, they can get iron deficiency anemia. In adults, peptic ulcer disease in male. Why? Because once the peptic ulcer rupture, it can sometimes damage an artery as well. We are going to be discussing that in our GI section, that if you have at the greater curvature, once you have an ulcer, which artery is going to be damaged in that case. That's also really high yield MCQ, which you guys are going to be tested on, right? On the small curvature, if you have an ulcer, which artery is going to be damaged, these are some high yield MCQs which you guys are going to be asked, right? So in that cases, in ulcer cases, sometimes if they are gastric ulcers, if you have duodenal ulcers, they can sometimes perforate, they can just, cause damage to an artery, and due to that blood loss, if you're losing blood, you're also losing iron in that case, right? You're losing iron in that case. Like, for example, in severe menorrhagia, right? in severe menorrhagia in pregnancy, we are losing our blood. And blood loss of blood directly corresponds towards loss of iron as well, right? Similarly, the hookworms and cholestoma and Necator americanans, they also leads to, they suck blood, right? They suck blood. If they are sucking blood, it means that it's directly corresponding of losing your iron as well, right? So it would lead to iron deficiency anemia. Does that make sense? Hello?
Yes.
Hello?
Yes.
Okay.
Yes, sir.
Okay. Okay. That's perfect. So let's just discuss another concept. Remember, we discussed we have heme and we have globin. We discussed that heme basically is made up of iron plus protoporphyrin, and globin can be your alpha globin and beta globin chain. Remember, the iron which is basically bounded to protoporphyrin is basically present in plus 2 state. Only plus 2 state of iron can bind to protoporphyrin. Only plus 2 state of iron can be bound to protoporphyrin. And remember, your gastric HCl, basically the acids, tend to keep your iron in plus 2 state. HCl in your stomach basically tend to keep iron in Fe plus 2 state. Keep that in mind. So whenever we have gastrectomy, if you are just cutting the stomach, let's suppose, we would be losing the acid effect on this iron as well. So now the iron cannot stay in Fe plus 2, but it would stay in Fe plus 3. And Fe plus 3 can never bind to your protoporphyrin. So can I say an individual with gastrectomy can develop iron deficiency anyway? Still he have iron. He have plus 3 iron, but you cannot, utilize that iron. You cannot combine it with your protoporphyrin. So what's the use of that iron? Obviously we are going to have an iron deficiency anemia. Does that make sense?
Yes, yes.
Okay, so gastrectomy acids, just keep that in mind. It's really important, right? The other one is storage. Okay, whenever we have iron deficiency, the first thing which would go down are your storage molecules. Keep that in mind, right? The first thing which would deplete are your ferritin, your storage molecule. That's really important. You have a UWorld MCQ on that as well, right? Which would be the first one to drop? That's going to be your ferritin, right? Then your TIBC. Okay. So for example, if I have iron deficiency, the ferritin are going to go down. If the ferritin go down, what do you think will happen to TIBC? I just already told you the relationship between ferritin and TIBC to you guys.
Increase.
Increases.
Increase they have and that makes sense. If the stores are low, so what your stores are going to do, they are going to call your liver, just please make some transfer in. I'm very deficit with iron. Just please make some transporter so that they can restore me, right? That makes sense, right? So the TIBC also is going to go down, right? And then you're going to be having serum depletion as well because the iron comes into the blood from these ferritin store. If you have less ferritin store, less iron is going to be present in the serum. So the serum iron is going to be depleted, and a stage would come that even the percentage is going to be depleted. If you have too little iron in the blood, obviously the normal if normal percentage saturation is 33, that would also go down because you have very little amount of iron to get bound into those transferrin molecules, right? Okay, here is a really important and really high yield stuff which you guys must remember, and your NBMEs, your Jew world, they're going to they love to test you on this thing. Whenever we have iron deficiency anemia, we directly do not develop microcytic anemia. Keep that in mind. Okay, we know that the iron deficiency is a slow and gradual process. It's not that it would just occur in seconds, right? It's a slow and gradual process, right? So as your body is sensing this gradual decrease of iron inside your body, so first of all, what your body is going to do, it would not directly jump into microcytosis. First of all, it's going to cause normocytic anemia. What do I mean by that? If you have less iron, less content, first of all, it would decrease the total number of red blood cells so that the remaining iron can be well distributed through the red blood cells, right? So the first phase in this gradual decline of iron is going to be normocytic anemia. Is it clear? And as the normocytic anemia, further we have decline in the iron, normocytic anemia then is going to lead to microcytic anemia, right? Does it make sense?
Yes, yes.
Yes.
Thank you.
Okay. So directly it won't jump into microcytic anemia. First of all, it have to pass through a phase of normocytic anemia, right? It's really important because sometimes they're going to tell you we have an individual, he's having an iron deficiency anemia. Suddenly you just think, yeah, that's microcytic anemia. But in the question venient, they're going to be giving you the values of normocytic anemia. They'll just confuse you, but you should think of, they can give you the scenario in this gradual state. They can give you normocytic anemia. But in your mind, you should be thinking that it is one of the phase of getting into those microcytosis. Does that make sense?
Yes.
Okay. And then when further the level of iron decreases, then we're going to have microcytic hypochromic anemia. Let me just tell you, as we discussed, it's a gradual process, right? Gradual decline of your iron. So first of all, normocytic anemia, normal red blood cell, but the total amount of red blood cells are going to be decreased. Then microcytic anemia, okay. Now you'll be having small red blood cells in that we have concentrated. If we have further decline of iron, then we are going to be having microcytic anemia, microcytic hypochromic. What do we mean by hypochromic? Chromic simply mean colors, less color. What is the color being given to red blood cell? That's your hemoglobin. So hypochromic directly indicates towards the level of your hemoglobin, right? So now, first of all, normocytic anemia, then microcytic anemia, then microcytic hypochromic. So micro hypochromic means that it would be microcyte, but further the level of hemoglobin is going to be too less color in it, too less hemoglobin in it, right? So you should just think it's a gradual phenomenon. Does that make sense? Hello?
Yes,
Yes.
sir.
Yes.
Okay, perfect, right? So if we have, okay, so if you do not have iron, what would happen to the level of protoporphyrin? They will always wait to get iron, but they won't get iron. So that as comparatively to your, if you're just comparing it with the level of iron, the protoporphyrin level would rise, right? So we'll be having free erythrocyte protoporphyrin, FEP, okay? Because they'll be waiting for iron and we do not have sufficient iron. So as compared to the iron, the level of free erythrocyte protoporphyrin would increase, right? What's the treatment? Iron supplementation, ferrous sulfate. Really important. Keep that in mind, right? So we have something called Plummer-Vinson syndrome. What is Plummer-Vinson syndrome? Do you guys have any idea of that? Hello?
Yeah.
Yeah,
Um,
it
Because
consists of
it's a fragile web.
esophageal webs and iron deficiency.
Awesome.
Yeah.
yes.
Perfect. So this syndrome basically consists of three things. Keep that in mind. Esophageal web. What is esophageal web? For example, if this is your esophagus and you have your mucosa, right? So the outgrowth of mucosa, when sometimes you can have outgrowth of that mucosa, and this outgrowth is simply known as esophageal web, right? So if we have
Yes.
esophageal web, it's obvious that we are going to be having dysphagia. An individual cannot eat food because in the middle you have a big hurdle obstruction there, right? You can just simply think of. So in this case, you can just relate it with Plummer-Wilson syndrome in such a way that his diet won't be proper. If he's experiencing dysphagia with eating, so he won't eat. So if diet isn't proper, so he can develop iron deficiency anemia, right? Iron deficiency anemia, right? You can develop iron deficiency anemia. So dysphagia, iron deficiency anemia, and sometimes the glottis part is going to become atrophic. And as it becomes atrophic, the blood vessels which are present in the glottic area, they would just appear red, right? So this entire red appearance is going to give, the glossitis or inflammation of your, glottis area, and along with that, the tongue is also going to appear red due to exposure of that subepithelial blood vessels, right? So we have three things: esophageal web, which is going to lead to anemia,
Mm-hmm.
atrophic glossitis, and beefy red tongue. Why do we get beefy red tongue? Because of that atrophy of superficial mucosal layer, the red blood vessels are going to expose, and it's going to give that green color. Does that make sense?
Yes.
Perfect. So let's discuss our next topic, that is anemia of chronic disease. It's really simple, right? Really simple. But before getting into anemia of chronic disease, let me just tell you one thing, right? Whenever we have chronic inflammations, right? Chronic inflammatory diseases. For example, you can have SLE, you can have rheumatoid arthritis. These two things are really important to keep in mind. Rheumatoid arthritis, SLE, they are chronic diseases, right? Chronic autoimmune disease. Sometimes what
Yes.
happens? Your liver release something called acute phase reactants. Acute phase reactants. What are the function of those acute phase reactants? In chronic inflammation, these acute phase reactants are going to save your body from bacterial infection, because if you have chronic inflammation, if you have chronic disease, it means your immunity is going to be down for chronic period of time. So for that, okay, which interleukin was important for release of acute phase reactant? You guys know that interleukin 6. Remember?
1 and 6.
One.
Okay,
One
one and
six TNF alpha.
okay, 160 NF alpha. Okay, so what these acute phase reactants are going to do? They are going to save your body in chronic inflammation. Okay, so one of them can be hepcidin, right? One of the acute phase reactant can be your hepcidin. So what your hepcidin is going to do? It's going to enter into your, okay, it's going to be released in the blood. It's going to go to that storage site ferritin, and it would tell the ferritin that you won't release iron. You won't release iron. Why is he doing it? This hepcidin is doing it because iron is really important for bacterial growth.
Mm-hmm.
For bacterial growth, right? So in chronic inflammation, hepcidin basically sequester the iron in ferritin store. They won't allow the ferritin to release iron. And why are they doing it? They are doing it because iron is important for bacterial growth. So if like according to hepcidin, it's doing a good job, right, in chronic inflammation to save me from bacterial growth. If you do not have iron, bacteria cannot grow. But the main effect of that would be if iron isn't coming out of ferritin, it can never participate in formation of heme. That's the side effect. It can never participate in heme formation. So if it do not participate in heme formation, what would happen? Would we develop iron deficiency anemia?
Yes.
Hello?
Yes.
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 If we aren't allowing iron to come out of that ferritin store and they are never participating in the heme synthesis, heme is less, hemoglobin is less, microcytosis anemia. So can I say that anemia of chronic disease, in chronic disease due to acute phase reactant, sequestration of the iron into the ferritin store, we can have iron deficiency anemia, right? Which is going to be
Mm.
an example of microcytic anemia, right? So let's just
Yes.
read our text, what they are saying, okay? Anemia associated with chronic inflammation like endocarditis, autoimmune diseases, I just told you, rheumatoid, SLE, keep those two things in mind that are really important, right? Okay, what would happen? The common type of anemia in hospitalized patient, obviously. Okay, so what would happen? It would result in acute phase reactants from liver, for example, hepcidin. What this hepcidin is going to do? It's going to limit the iron to come out of from your from
Macrophages.
from the macrophages, from the ferritin store, right? And as the
Mm.
iron aren't coming out, so what would happen as a result of that? You guys can see it here. Okay. Okay. So what would happen? Protection. Okay. The aim of this would be to to not allow the bacterial overgrowth. But the other side effect of it can be that you can have iron deficiency anemia. So can you guys just tell me the lab finding in this case? What would happen to the ferritin store in anemia of chronic disease?
It would be normal.
Normal
Normal
Increase.
or increased?
TIBC would be low.
Mm-hmm. Okay. The ferritin would be normal or increased?
increased.
Increase.
It would be
Increase.
increased because we aren't allowing the iron to come out. We have caught them, right? So the ferritin increase. So what would happen to TIBC whenever the ferritin increase? We know the relation.
Decrease.
Below.
Okay. Low. What would happen to the percentage saturation?
Iron
Low.
saturation increased,
Low.
right?
Okay.
No?
Yes.
Oh,
Yes. It would decrease, right? So the treatment is just go for the underlying cause. Just treat the chronic disease. What's the underlying cause? If it's rheumatoid arthritis, try to just treat that. If it's SLE, try to treat that. It's difficult to treat them, but you do not have any other option for that. Okay, is it clear?
yeah.
Okay.
Okay.
So this was all about iron, right? We discussed iron. Now, okay, so we have heme. We discussed heme is made up of iron and protoporphyrin. For the iron, we discussed if we have decreased dietary intake of iron or we have anemia of chronic disease, right? It can
Yeah.
give us iron deficiency anemia. Now let's just come towards protoporphyrin. But before discussing protoporphyrin, you should just know the pathway how the protoporphyrin are made. Keep one thing in mind. We have an enzyme which is called as ALAS, right? What this ALAS is going to do, it's going to take your succinyl coenzyme A, along with that, it's going to take the B6, right? And it's going to convert it into ALA, which is aminolevulinic acid, right? Then we
Yeah.
have another enzyme, ALAD. It's going to act on aminolevulinic acid and it's going to convert it into porphobilinogen, right?
Oh.
Porphobilinogen then is going to undergo some chemical, reactions, and in the end you can have protoporphyrin, right? Protoporphyrin. But as we have protoporphyrin, now we need iron to get attached to this protoporphyrin as well. So the enzyme which does this job is your ferrochelatase, right?
Chile.
Ferrochelatase. Ferro mean your iron, chelatase or chelating agent, or some people call it chelating agent, right? So ferrochelatase would just take iron and put it into protoporphyrin, and then you have that proper heme, right, which can participate in hemoglobin synthesis. So this is the
Yes.
normal pathway. ALAS would take B6, it would take succinyl coenzyme A, it would just convert it into aminolevulinic acid. ALA dehydratase is going to act on it. It's going to convert into porphobilinogen into protoporphyrin. Ferrochelatase taking iron and putting it into protoporphyrin. This is the normal pathway, right? So you guys can see it here. Okay, let's read it. Immunolenic synthase, coenzyme, it just took coenzyme A, it took B6, then ALAD on porphobilinogen, and that you have ferrochelatase attaches iron to that. That's simple, right? Okay.
Mm.
Remember one thing. For example, if you do not have this enzyme, can we make protoporphyrin? No.
Mm.
If we can't
No.
make protoporphyrin, we won't be
Mhm.
making heme. If we can't make heme, we cannot make hemoglobin. If we cannot make hemoglobin, that would be microcytic anemia, right?
Mhm.
Okay, that's perfect. Okay, so remember one thing in mind. If again, if we have B6 deficiency, again, we cannot just whenever any intermediate in this pathway is affected, we are going to have microcytic anemia. We know that, right? Okay.
Mhm.
So remember one thing: alcoholism. All of this process basically occurs in mitochondria, right? So you
Mm.
can see this is your iron. For example, if the ALA you have congenital deficiency of ALAS, what would happen? You cannot make protoporphyrin, but still the iron would be present there in the mitochondria, right? Waiting for the protoporphyrin to be made and just waiting for combination of them to make heme. Okay,
Mhm.
similar.
Mhm.
Okay, we have lead. What do lead do? Lead is basically a poison which can inhibit your two enzymes, ALAD, okay, and ferrochelatase.
Days.
Okay,
Yeah.
so whenever we have lead poisoning, we won't be having function of these two enzymes. If we do not have function of these two enzymes, again the iron would be waiting there. You cannot form protoporphyrin. You can never make heme. If you can never make heme, you can never make hemoglobin. You'll be having microcytic anemia. That's obvious, right? B6 deficiency, an individual having TB given isoniazid can cause B6 deficiency. We know that, right? So if he have
Mhm.
B6 deficiency, again he cannot make protoporphyrin. If he cannot make protoporphyrin, again iron will always be waiting there for protoporphyrin to be made, but it would never get iron. So or it would never get protoporphyrin. It would never form heme. So what this iron is going to do sometime, it's going to stay within the mitochondria, right? So if this is your mitochondria, it would just keep on staying there. But as the protoporphyrin are not made, so sometimes these mitochondria filled with iron can accumulate and they can surround your entire nucleus, giving you a ring sideroblast. Ring sideroblast. Does it make
Okay.
sense?
Yeah.
Okay, iron waiting there in the mitochondria, they just form a ring around your nucleus. That's called as ring sideroblast. So let me just call this anemia as sideroblastic anemia. Blast is a cell. Siderin is iron accumulation. Sideroblastic anemia is a microcytic anemia. Can I say that?
Yes.
Perfect. So you can see alcoholism would cause that, lead poisoning, B6 deficiency, tuberculosis isoniazid, really important, really high yield. Okay, so it would just form a ring sideroblast, which is known as sideroblastic anemia. You can see it here, the left finding, what would happen to the ferritin? Ferritin R increase, right? Okay, what would
Mhm.
happen to the TIBC?
Increased.
Increase, okay? And the percent, because you already have that those ferritin store which can dump iron into the blood. So the transfer in percentage, saturation, and everything is going to increase. Okay,
Mhm.
so that's really important to know. Let's discuss our next topic, thalassemia, which is really important, right? Before discussing thalassemia,
Sir,
do you have any
does
questions?
metformin also cause microcytic
That
anemia
that that,
because
that
it
cause
causes?
B12 deficiency. That do not cause
Okay.
B6 deficiency. That's B12 deficiency, right?
Yeah,
That's
yeah.
microcytic anemia.
Okay. Okay. So let's discuss thalassemia, right? But before getting into thalassemia, just give me a second. Okay. Just give me 1 second. Let me just erase it first. Okay. Okay. Remember one thing. You have alpha chain and you have beta chains. Okay. Let me make it really simple for you guys. On chromosome number 16, you have you have four genes for your alpha, right? So for example, if it's your one chromosome and it's your other chromosome, right? So one, two, one, two. So you have one, two, three, and four genes to encode your alpha chain. That's simple, right?
Mhm.
Okay. For example, if we have deletion of this one alpha chain gene, we won't have any problem in that individual. Remember, right? It's going to be really minor kind of thalassemia, right? But if we
Mhm.
knock off two genes, it can cause problem because we have total of four on two different chromosomes, right? Total of four, or which chromosome? Chromosome number 16. We have total of four on two different chromosomes. If we know, okay, it's basically going to be due to gene deletion. Alpha is due to gene deletion. If you delete one gene, no problem. But if you delete two genes, we can have two scenarios here. Either we are deleting gene on this one on this, and one on the other, or either we are doing both on the same. Does that make sense?
Mhm.
Right? Like if you are
Yeah.
deleting two genes, so either the case would be that we are deleting it on the same chromosome, or either we are deleting one from one chromosome and one from the other chromosome. So if we are deleting two genes on same chromosome on same side, that's going to be called as cis deletion. Cis means same side deletion, cis deletion. And if we are just knocking off one on one chromosome and other on the other chromosome, that's going to be trans deletion. Trans deletion. That's really important. So cis deletion is problematic for offspring. Why? If someone is having this cis deleted gene, right, and let's suppose a mother, right, and the mother transmit it into offspring. So obviously the offspring on the first is going to be having these two deleted genes on this chromosome, and by any chance if he get a single one from the father, it would just delete. We'll be having deleted three deleted chromosome, and it would just cause a lot of problem. Alpha thalassemia major, right? Okay, but if we have transform, that is if if only one is deleted from this one and other is deleted from this one, if we get this gene into the baby, right, so we'll be having something like that, one deleted. So by any chance if this baby get defected from the father as well, so he'll be having total of two deleted, which won't cause that problem, right? One or two won't cause that problem, right? Is it clear? So if we have one deleted gene, no problem with an individual. If we have two deleted gene, minor problem with the individual, but major problem with the offspring. Does that make sense?
Yes. Yes. Yeah.
Okay. One deleted, no problem for an individual. Two deleted, minor problem for an individual, but big problem for the baby. If it's a trans, then minor problem for individual and minor problem for the baby. Does that make sense? So cis is really
Please, can you explain it? I'm not getting it.
okay. No problem. Let me just do it. Okay. So we have four chromosomes. Mhm. Okay, one, two, three, four. Okay, if one is deleted, no problem, minor. If the second is deleted, no problem for an individual. But in the two deletion, we have two cases. Either the second can be deleted on this chromosome, on this single chromosome, or either one can delete from this one and other can delete from this one. Does it make sense? If we delete both on the same chromosome, that's cis, right? If we delete one from this chromosome and one from the other chromosome, that's going to be
Right.
called as trans. Okay. Okay. Hello. For example, if you have a mother with cis condition, right? So let's suppose she just transmit this gene, this defective bad gene into the baby, right? So the baby is going to get this defective gene of cis variant. Two of them are deleted on the same one, right? Okay. By any chance if the same baby get one defective or a bad chromosome from the father, so total of three are going to be deleted in that baby, right? It's going to be a
Yes.
major problem then, right? So
Mhm.
if two are deleted in an individual, that's a minor problem for him. If that's cis, that's a major problem for the baby. Major problem for the baby. Like for
Mm.
example, if let's suppose this was a trans variant, right? The trans variant. If a mother give this trans variant, let's suppose this is the baby would only have this single defective. If the baby get another single defected from the father, so total of two are going to be deleted in the baby, and it would be a minor problem for the baby, right? But in this case, it was a major problem if by any chance the baby get single defected from the father. Does it make sense?
Mm.
So cis variant is bad for offspring. Okay, cis variant is bad for offspring. Is it clear? Yes or no? Or shall I repeat it again?
Yes. Yes. I understood.
Okay, perfect. So cis is going to be problematic for baby. Trans is going to be minor for both. Minor problem for both the individual and baby. Right? It's going to be one of your UL MCQ that are going to ask you that. Okay, keep that in mind. Okay. So let's just discuss. Okay, so we were discussing we have four genes. If we have, okay, so we were discussing that if, okay, these were your four genes. Let's suppose if one is deleted, no problem. If two are deleted, little problem. If three are deleted, major problem. But if four are deleted, a big problem. So whenever the three of them are deleted, so the remaining, okay, these were your alpha chains, right? Okay, so okay, so in the baby, okay, so the remaining, okay, alpha is bound with which chain? With the beta chain, right? Hello? Hello. Alpha 2
Yeah.
and beta 2, that's the normal one, right?
Yes.
Yes, sir.
Okay.
Alpha
So
beta.
if three of them are deleted, so what would happen? The remaining beta chain would just form a tetramer, right? They can just form a tetramer, which can damage your red blood cells. Keep that in mind. But if the four of them are deleted in the baby, let's suppose if the baby do not have any alpha chain, so the baby do not have beta, they have gamma, right? So the gamma would then form a tetramer. Does that make sense?
Mhm.
And the baby with this tetramer of gamma won't survive. We are going to be having a condition called hydrops fetalis. Baby is going to be dead. Adamat is that baby, right? That's hydrops fetalis. But because why? If you do not have alpha, obviously the gammas are going to make this that tetramer, which can again destroy your red blood cell, and the both baby won't survive, right? So these were the normal variants in alpha. Let's just refer towards this text, what they are saying. Okay. So you can see that they are present on chromosome number 16. Okay, so if one is deleted, it's asymptomatic, two are deleted, mild anemia. But if two, then we have cis variant and trans variant. Cis, both deletion on same chromosome seen in Asians, trans seen, one on one chromosome, one on the other seen in African Americans. Okay, if three are deleted, severe anemia, the other can form hemoglobin H, the beta can form, and it would damage the red blood cell. If four of them are deleted, of the gamma would form chain hydrox fetalis, hemoglobin bark, right? Okay. Is it clear?
Yes.
Hello?
Yes.
Perfect.
Yes.
Okay. Let's go for beta. Beta, right? So for the beta, it's really simple. First of all, we discussed alpha was due to gene deletion. Beta is due to gene mutation. Which mutation? Point mutation. One of your UL MCQ. Point mutation. Point mutation. One of your UL lines. Simple. Okay. So it's due to mutation. So simply you can think of if it's mutation, it means we can have two cases. The mutation could be till certain extent that no B is going to be made, right? No B is going to be made. Or either the mutation can be a little bit mutation, that is, no half or little B can be made, right? Okay, since it's not deletion, it's mutation. So we can have two variants. Either the mutation can be enough severe that no B is made, or either it can be to certain extent that half or little of B is made, right? So let's discuss the two scenarios which we can get. We can have, okay, we'll be discussing two extreme cases, right? So we can have one normal beta and other beta plus, right? So if you have a normal beta chain and a beta plus making less hemoglobin, it will be a mild beta thalassemia, right? But if we have beta naught with beta naught, that is zero amount of beta being made, both of chromosomes. So what would happen? Both of genes are making zero beta. It would be a major beta thalassemia. Is it clear?
Yeah.
Okay. So okay, you should just keep this thing in mind. It's mutation on chromosome number 11, right? That was on 16. It was on 11. We can have a mild form that is less beta being made or no beta being made. A normal beta, normal. Let's discuss two extent, right? A mild case and severe case. So minor beta thalassemia and major beta thalassemia, right? Again, we are going to be having microcytic hypochromic anemia. We know that whenever the chains and everything we discussed in the beginning are defective, we are going to be having microcytosis, extra division in order to compensate the decreased amount of hemoglobin, right? Is it clear?
Yes. Thank you.
Okay, perfect. Now keep one thing in mind. We are going to get something called target cells in beta thalassemia. We'll be discussing the target cell concept. How do we get target cell concept in our other topic that's going to be G6PD deficiency, in which again we are going to see these bite cells in G6PD and target cell in sickle cell disease. Keep that in mind, right? So there we'll be discussing the concept of these target cell. But you should know these are the target cell. You can see in the middle they have a target kind of spot present in the middle. Normally we must be having the central payload. That is the central portion of the red blood cell won't have any hemoglobin. But if we have hemoglobin, the central area of that red blood cell, that's basically called as target cell. Okay, is it clear? Hello.
Can you
Yes, sir.
explain one more time about target cell?
Okay. Remember one thing. Okay, let me just tell you. Okay. Whenever we have beta thalassemia, it means that the amount of hemoglobin which you are making are less, right?
Mm-hmm.
Okay, so there would be problem with redistribution of redistribution of hemoglobin within the red blood cell. How? Normally, the
Okay.
red blood cell is having a central payload. The central
Yeah.
payload suggests that we do not have hemoglobin in the central part of. I just told you chromatic. Chromatic was the color of red blood cell, and the color to red blood cell is being given by your hemoglobin. So if you have
Hemoglobin.
a paler, if you have a paler, it means you do not have color. It means you do not have hemoglobin there in the central portion of your red blood cell, right?
Okay.
But in target cell, we will be having hemoglobin in that central area, right? You can see it
Uh,
here. Okay,
okay.
so we'll be
Okay.
discussing the entire pathophysiology, that how do we get that here, right? But that's not necessary now, right? We should just
Oh,
focus on the extra the other topic, right? So for
okay.
example, if you have beta thalassemia, just remember target cells, right? Target cell, because we're going to discuss this target cell again in another topic where we need to do it in detail, right? Okay,
Okay.
so listen one thing. Okay, so we can have beta thalassemia. So we discussed two conditions. Either we can have a mild form, that is normal B with a B plus, that's going to be microcytic anemia, and either we can have beta node. In that case, your alpha is going to undergo tetramer formation, which can damage red blood cell, right? So in
Oh,
case of beta thalassemia, as we are making very less red blood cell, so what your body is going to do, keep one thing in mind. Initially, the red blood cells were okay. No, normally, where do we have formation of red blood cells? In the long bone marrows, right?
uh-huh.
In the bone marrow of long bones. But initially, the story wasn't the same. Initially, your skull bones used to give you your red blood cell. Your facial bones were responsible in giving you your red blood cell. Your spleen was responsible in erythropoiesis. Your liver was also having a role in making red blood cell for the fetus or for the baby, right?
Mm.
That
Yeah.
was a primitive. But as an individual grow with age, this job is being taken by your long bone, the bone marrow of your long bones, right?
Sister,
So in this case,
patient number கொடுக்காதீங்க sister.
hello, Dr.
ஆ
M.O. Dr. M.O. Let's listen,
நீங்க
Dr. M.O.
தரலையா?
conversation.
யார் கொடுத்தான்னு தெரியல. ஓகே ஓகே ஓகே
Okay.
கொடுக்காதீங்க என்ன? ஓகே ஓகே.
Okay.
Okay. So let's continue it now, okay? Doctor, why you're very naughty? Okay. Hello. Okay. So we discussed that in the primitive ages, your red blood cell was being made by your skull bones. It was being made by your facial bones. It was being made up by your liver and spleen. In this beta thalassemia, again, we are having so great demand of red blood cells. Why? Because we need red blood cells, but they cannot be made well. Because in the beta node and beta node variant, you cannot have red blood cell formation. So what your body is going to do? Your body is going to call that primitive organs to please make some red blood cell for me. It's not only true in case of beta thalassemia. You can see it in other diseases, like for example in sickle cell disease, where we require erythropoiesis, where we require a lot of red blood cells. So your body is going to tell that primitive organs to please make some red blood cells for me. Which
Mm,
primitive organs? Your skull. So as your
mm,
skull is now attempting to give you your red blood cell, so the skull bones are going to protrude. It's going to give you something called crew cut appearance, right? Because
mm,
now your skull bones are working, they are giving an attempt in order to make red blood cells, but in that attempt, we are stimulating the bony processes. So we can have a small bony outgrowth on the skull, which is basically going to appear as crew cut appearance. You guys know what is crew cut? That small cut which you basically, maybe and the army people do, right? Crew cut appearance, right? And that's
mm,
why, because we are just stimulating our skull bone to make some red blood cells. If you are stimulating the facial bones to please make some red blood cells. So what would happen? The facial bone would appear as a chipmunk faces, right? The faces are going to, the bones are going to enlarge and they're going to give you chipmunk faces. So in your question variant, when on the X-ray, you have these screw cut appearance and you have these chipmunk faces. Think of any condition which have increased the demand of red blood cells or erythropoiesis. That's why, okay? So that's basically known as extramedullary hematopoiesis. Normally, this area where your bone marrow is present, it's called medulla of the bone, right? So
mhm,
extramedullary outside of the medulla can be your skull, your primitive organs. It can be your faces, facial bones. It can be your liver. It can be your spleen being made, making your red blood cell undergoing erythropoiesis. Okay, so
mhm.
that's really important. But as in this condition, we are largely dependent on these, bone marrow precursors, right? So at that time, if we have infection by a virus called parvovirus B19, which is, being inhaled by your respiratory system, and it can just get into your bones, and it can just cause these hematopoietic stem cell to be, temporarily hard. They would temporarily halt the activity, and we can have a severe problem in that case, right?
Mhm.
Is it clear? Okay.
Yeah.
So, the okay. So, what would be the treatment option for an individual beta thalassemia? We all know that we are going to give them transfusions, right? But it can
Mhm.
develops into secondary hemochromatosis. Remember one thing: it's really difficult for your body to get rid of iron. It's really difficult for your body to get rid of iron. How do we get rid of iron? It's really slow process. Like normally, if you want to get rid of iron, so basically your blood is going to throw that iron into your mucosa of your GIT, and as the mucosa of GIT get renewed, then that iron is going to be released with that mucosa. So it's a really slow process for you to get rid of the iron, right? That's really important. So an individual with beta thalassemia, we are constantly giving him transfusions. We're constantly giving him transfusion. So as I just told you, your red blood cell, you can correspond it to or correlate it with the iron, right? So it means we are putting a lot of iron into them. So it can be secondary hemochromatosis can be caused, right? Let me just throw a U-word MCQs towards you. We have an individual, we were having a lot of blood transfusion, suddenly he developed hypocalcemia. Why?
The citrate is taking the cap.
Perfect. Citrate, chelator, right? Chelator. Citrate.
Yeah.
Okay, perfect. Okay. So you can see it here that we can have these target cells. Along with that, we'll be having little hemoglobin A because beta is one of the component of them, right? So this was all about, okay, your microcytosis, microcytic anemia. Let me just give you a quick overview in 1 minute, right? That's so simple, right? Microcytosis, less content, extra division. Iron, less iron. How can we get less iron? Dietary less intake, or no infection, chronic infection, sequestering that iron. Both of them are going to give you iron deficiency anemia. Ferritin store in one is low, the IBC is high in dietary. The other one, ferritin are high, the IBC is low. Right. The other one is protoporphyrin. We know ALAS, succinyl coenzyme B6, then ALAD making protoporphyrins, iron is staying there. If you have problem with these enzymes, for example, isoniazid, decrease B6, alcohol, direct poison of your mitochondria, lead, blocking your ALAD, and ferrochelatase, iron is going to stay there. It's going to make a round kind of,
Yeah.
ring around your nucleus, sideroblastic anemia. Okay. Okay, thalassemia, alpha, beta, alpha have 4 chain, beta have 2, alpha is 16, beta is 11 chromosome. You can have deletion in alpha, mutation in beta. One deleted, no problem. Two deleted, problem with an individual, minor problem in an individual, but we have two cases here, cis or trans. If it's cis, problematic for the baby. Trans, not that problematic for the baby. If it's 4, hemoglobin BART, hydroxytalis. Beta thalassemia, let's discuss to extent. Mutation on 11 can have less or you can have absent. If you have absent, it's again go to microcytic anemia, right? Extramedullary hepatopoiesis, chipmunk faces, crooked appearance, parvovirus B19 at that time is going to cause a lot of problem. Blood transfusion can cause secondary hemochromatosis, microcytic anemia, and that's all. It was difficult. I think that was simple, right? Okay. So let's just move to our next topic, that's macrocytic anemia, right? Okay. So the macrocytic anemia, you should just keep one thing in mind. Okay. Okay. I would highly recommend you guys that before going into your first aid, first of all, you should do your pathoma, right? These chapters are really highly to read from pathoma. In order to have good understanding of these chapters, you must be referring towards pathoma, right? Okay. Let's just start our next topic, that is macrocytic anemia. Before discussing macrocytic anemia, let me just tell you a concept where I just told you in microcytic anemia. How does the cell get divide? How does the cell divide? Cell divide. Okay, how does the cell divide? They use chromosomes, right? Chromosomes have DNA. So can I say that DNA is important for cellular division?
Yes.
Okay. It means if I do not have DNA, I won't be having proper cell division. If I do not have proper cell division, cell is going to stay big, right?
Yes.
Macro side. Okay. So this DNA is going to be okay. The effect of less DNA or improper DNA leading to that big cells are going to be seen in those cells who are highly dividing cells. Highly dividing cells. Okay, which are highly dividing cells? Your epithelium, your mucosal cells are highly dividing cells. Their turnover is really high. So it means they depend on the DNA activity a lot, right? They depend on DNA activity a lot because their turnover is high. The neutrophils are highly dividing cells, highly metabolically active or dividing cells. It means that they are highly dependent on DNA. Your red blood cells are also highly dividing cells. They only have 120 days of time span in which they are gonna renew, right? So it means that if we affect DNA inside your body, these three cells are going to be the first one which are going to show symptoms of that decreased DNA because they are highly dependent on DNA activity. Am I right?
Yes.
Okay, perfect. So how do we make DNA? Let me just tell you that, right? We need something called folate. Okay, folate. Folate is really important to make your DNA. I'm just making these things simple, right? Folate is really important to make your DNA. Okay. How does the folate get into the DNA making cycle? Folate normally is bonded with methyl, right? So in order for the folate to go into the DNA synthesis cycle, it have to give this methyl to B12. Okay.
B12.
Okay. Once the B12 receive this methyl, the B12 is going to give this methyl to homocysteine. Did you guys remember this? I just taught you this entire part, right?
Yes.
Homocysteine then is going to be converted into methionine. If we do not have folate, if we do not have folate, can I make DNA? No. If I cannot make DNA, can I undergo cell division? No. It means that folate deficiency is going to lead to macrocytosis. Can I say that?
Yes.
If I do not have B12, can folate get rid of this methyl? No.
No.
And as the folate cannot get rid of this methyl, folate cannot participate in DNA synthesis. Again, can I say B12 deficiency is again going to be giving me macrocytosis? Big cells, not divide, not division, big DNA, okay? Okay, and along with that, the homocysteine level are also going to develop, which can cause endothelial damage, which we discussed, where called triad, which can cause hypercoagulable states, right? Is that clear?
Mhm.
Perfect. So this was the normal concept. Now let's refer towards our text, right? Okay. So here you guys can see, okay, macrocytic anemia, macrocytosis, MCV is going to be greater than 100. 100 is normal, greater than 100 means macrocyte. How do we get that? Folate or B12 deficiency. If you have folate deficiency, you're going to have macrocytosis, no DNA, no cell division, big cell. If you have B12 deficiency, no DNA, no division, big cell, right? We discussed the methyl tetrahydrofolate giving methyl to this and participating and everything, right? Methyl is transferred to B12, B12 is going to transfer it to a homocysteine, converting into methionine. Homocysteine can cause damage to your endothelium, which can increase the hypercoagulable state. I just told you, right? Okay, lack of folate and B12 impaired DNA precursor synthesis. We know that impaired division is going to affect which cells? Highly dividing cells. Which cells? Neutrophils. So the neutrophils are going to be hyper segmented. Normally the neutrophils have 5 lobes, but if we have greater than 5 lobes within the neutrophils, that's a big neutrophil indicating toward macrocytosis, indicating any problem with folate or B12, right? I just told you, highly dividing cells are your epithelial cells. So the epithelial cells are also going to be having megaloblastic or big changes. Keep that in mind. Okay.
Mhm.
Hello. Okay.
Yeah.
So let's discuss folate deficiency. From where do we get folate? We get folate from vegetables and fruits if they are being reabsorbed in the jejunum, right? Folate deficiency developed within months because normally we have very little supplies of folate inside your body. The storage is very less, right? So if you have folate deficiency, you're gonna have deficiency of that in months, right? Alcoholics, really important. In your UL MCQ, they're going to be telling you have an individual, he's just drinking a lot of alcohols and this and that. You have some megaloblastic changes, that's going to be folate deficiency, macrocytic anemia. Elderly, right? So in alcoholics, folate deficiency, really important. Just note it down, right? Okay.
Mhm.
So increased demands. For example, if we have increased demand of folate, how? In pregnancy. In pregnancy, we are making baby. We are making baby DNA. We need folate. If the demand of folate is more, so demand to supply mismatch. If, for example, if we have less folate and we are making a baby, right? Maybe that folate was normal for the mother, but as the demand is high, in that cases we can have folate deficiency because the mother folate is being used by making your baby's DNA, right? Hemolytic
Mhm.
anemia. Okay, cancer cells also need DNA, folate, and everything, right? Folate antagonist, if I'm giving folate methotrexate, trimethoxam, sulfate, something like that. If I'm just giving antagonist of folate, they won't make DNA. If it won't make DNA, they won't undergo division. If they won't undergo division, it means we're going to be having a big cells, right? Hypersegmented neutrophils, glossitis. Keep that in mind. Really important. Okay,
Mm.
serum folate. Okay, what to decrease serum folate? Increase serum homocysteine. We know that, right?
Mhm.
Homocysteine is going to be more if you do not have folate because homocysteine would never receive that methyl if you do not have folate. So we can have hypercoagulable state, right? Normal methyl melanoic acid. It's really important, right? Really important. What is methyl malanoic acid? I'm going to tell you that in B12 deficiency. But it's high yield one, just memorize it. Believe me, it's going to help you on your exam day. Okay. Okay. Vitamin B12 deficiency. From where do we get vitamin B12? We get it from animal derived proteins. Remember, if we get this B12 in mouth, I'm going to attach something called R binder with B12. And once this R binder is binded to B12, it would just enter into your body. In the duodenum, your pancreas is going to remove this R binder from B12 and it's going to attach intrinsic factor to it, right?
Mhm.
And once
Mhm.
intrinsic factor get attached to B12, this entire complex is then going to be reabsorbed in your ileum. Is it clear?
Yes.
Okay. 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 In mouth, I'm going to attach something called R binder with B12. As it move into the duodenum, pancreas is going to pancreatic enzymes are going to remove that R binder, and then intrinsic factor can get attached to B12, and then you can reabsorb in ileum. So let me just throw some cases, right? For example, if I have pancreatic insufficiency, if someone is having, not me, sorry, okay, if someone is having pancreatic insufficiency, can we detach R binder?
No.
No.
Okay. If we
No,
cannot detach R binder, can we attach intrinsic factor?
no,
So can we reabsorb B12?
no.
No.
So can I say in pancreatic deficiency, B12 is not going to be reabsorbed? We can have macrocytic anemia.
Correct.
I
Yes.
I have a question, Dr. Muhammad.
Yes, please.
So the pancreas intrinsic factor is secreted from the stomach, right?
Yes.
Yes.
Uh, then how the pancreas is involved in the intrinsic factor?
Okay. 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 Let me just tell you. Intrinsic factor are basically made by your parietal cells, right?
Yes,
In order for the intrinsic factor to attach to B12, we need to remove this R binder.
correct.
Who removes R binder? Pancreas does that.
Oh, okay, okay,
If we
got
do
it.
not have pancreas, we cannot remove it. If we
Oh,
cannot remove it, we cannot attach intrinsic factor. If we
okay,
cannot attach intrinsic factor, we cannot reabsorb them in ileum.
correct.
So
Yeah.
we can
Okay.
have macrocytosis.
Mm-hmm.
Okay. For example, if the stomach parietal cells, if you have something called chronic gastritis, if the parietal cells are damaged, if we cannot make intrinsic factor, can
Mm-hmm.
we reabsorb B12 then?
No,
No.
no.
So if the intrinsic factor is absent, we cannot reabsorb B12. If we cannot reabsorb B12, it means that again we are going to be having macrocytic anemia, right?
Okay, okay.
Okay, if everything is fine, but in the ileum we have Crohn's disease, any inflammation in the ileum, can
Yeah.
we reabsorb then B12?
No, no.
Again, can I say in Crohn's disease and everything, we're going to have B12 deficiency macrocytic anemia?
Ye- Yes.
Yes.
Perfect. That's so simple, right?
Mm-hmm.
Look, salivary enzymes liberate, it would just attach B12 with R binder, pancreatic protease is going to remove R binder. If it's going to attach to intrinsic factor, the complex is going to be reabsorbed at ileum. Vitamin B12, B12 is less common than folate because normally we have a lot of source for vitamin B12. Keep that in mind. Pernicious anemia, whenever we have, okay, this autoimmune destruction of parietal cell, no intrinsic factor, we are going to have B12 deficiency. B12 pancreatic insufficiency cannot remove the R binder, Crohn's disease, and TAP, fishworm disease, inflammation of ileum, we cannot reabsorb. We can have, macrocytic anemia, that is hypersegmented neutrophil, glossitis. Remember one thing, B12 is really important for, okay, let me show you here on the next one. B12 is really important for converting your methyl melanoic acid to succinyl coenzyme A. B12 is also one of a cofactor for converting methyl melanoic acid to acetyl coenzyme A. If you do not have B12, methyl melanoic acid can develop a lot, and it can damage your spinal cord, central nervous system. It can damage the posterior column, which we'll be discussing touch pain, vibration, proprioception, everything, right? So, can cause problem there. It can damage the lateral tracts, which we'll be discussing. We have corticospinal tracts, and we can have spasticity as well. So, in a question stem, if we have folate deficiency, we only are going to see, you know, we only are going to see macrocytic anemia, but normal methyl melanoic acid concentration, as I already told you, really important because we have B12. But in B12, we are going to be having macrocytic anemia along with problems with the CNS, destroying a lot of portions of your spinal cord. So B12 is a cofactor which is used for conversion of methyl melanoic acid to succinyl coenzyme A, really important. And this disease, whenever the methyl melanoic acid increases and it just, destroy your um, different spinal cord tracts, they're going to be called as subacute combined degeneration of spinal cord, something like that. Okay. So B12 deficiency increase methylmalonic acid, damage to the posterior column, to the lateral spastic paresis, and B12, okay, thrombosis, homocysteine would also develop. Three problems: homocysteine develop, methylmalonic acid, and macrocytic anemia. So the B12 is, more dangerous than, this one. Hope so this topic is cleared. Any questions? Okay, let me just give you overview in 20 seconds. Okay, macrocytic anemia, no DNA, big cells, and no division. DNA made of folate, DNA made up of B12, no folate. How can we have no folate? We can have in alcoholics, very important. Folate, anti-folate drugs, macrocytic anemia, but normal methyl malonic acid, homocysteine develop. You guys know hypersegmented neutrophils, ATP. So the B12, you have a lot of stores. It would take a lot of time to develop B12 deficiency. Normally, we bind it to R binder in saliva, and it moves into duodenum. Pancreas is going to remove the R binder. It's going to attach it to your intrinsic factor in the ileum. They get reabsorbed. So let's start from beginning. Problem with pancreas: no R binder separation, no intrinsic factor attachment, no reabsorption of B12. Macrocytic anemia, three problems, right? Macrocytic, methyl malanoic acid, homocysteine. Macrocytic, thrombosis, and spinal cord lesions, right? Problems. Okay. Okay. No intrinsic factor, no parietal cell, chronic gastritis, no intrinsic factor, no reabsorption of B12. Again, three problems: macrocytic anemia, problems with the spinal cord, and homocysteine development. Okay, that's some. Okay, if we have everything is fine, but we have inflammation going on at the ileum, Crohn's disease, tapeworm. Again, no B12, three problems: macrocytic anemia, methylmalonic dystonia, or spinal cord, the posterior columns and the lateral corticospinal tracts, giving a spastic paresis, subacute combined degeneration of spinal cord. And along with that, we're going to be having homocysteine increase because homocysteine would never receive that methyl from B12. You can have thrombosis, one of criteria for your leukotriol. I think that was simple. Okay. Hello.
Yes.
Yes,
Okay,
sir.
so
Yes, sir.
we are only left with a normocytic anemia. So the time is up today. Time is finished. Tomorrow we are going to finish this entire module, and hope so you guys are enjoying the session with me. And that was all. And after that, we are going to discuss our final white blood cells. That's going to be the easiest of all. Believe me, right?
Doctor, I think
Yes,
we
please.
left with heme synthesis.
Heme synthesis. Okay. As I mentioned, first of all, we are going to do it from our pathoma, and
Okay.
that part is going to be covered once we are doing first aid portion of it. Okay.
Okay.
acute, intermittent pore, 5 years, and everything, right? So we are going to do that in first. Yeah.
Okay.
Thank you. Are you guys enjoying the session with me?
Of course.
Of
Okay.
course, doctor.
Awesome.
Yes.
Always.
So, do you
Okay.
have any
Thank you so much.
update on recordings?
Hello. Sorry.
Dr. Ahmed, do you have any update on the recordings, like the immunology boot camp and recording from
Okay,
yesterday?
okay. Actually, the problem was that we have recorded that through another Google Meet. So I was just setting it. I've just updated it, and I'll just send it in 4 to 5 minutes. Right. Really sorry for that.
The other recordings too. The Friday and Saturday, I guess.
Okay. So I'm only okay. I have to share two recordings. Are there in my drive? One for the boot camp and other for the U world. I'm gonna share both of them. Okay. The other are going to be updated. So really sorry. Let me mention about the recordings. Actually, it takes a lot of time, some time to come into the drive, right? It do not come directly to the drive. Then we have to crop it, and then we have to do a lot of things. So if they're delaying, so really sorry for that. It's we are just trying our best. It's not that we are just doing it. Okay.
Okay.
Thank you. So thank you so much. Thank you. See you
Thank you.
tomorrow.
Thank you. Bye-bye.
Thank
And
you.
one thing about assessment, who are left with the assessment, only 2 to 3 of them have just shared their scores with me. No one else. Please share the scores with me. I'm gonna write them down.
It's not automatically submitted when we submit the
Yes,
email.
it's automatically submitted, but please, if you guys can just send me a screenshot so we can have some fruitful conversation on that. If you guys have any problems, so we can just try to fix that individually. It would be really good for me. Okay.
Okay, sir. Thank you. Send it.
Thank you so much. Thank you. And you guys are doing quite great, right? I'm so impressed from this batch. All of them are scoring 80 to 90%. So impressive. No, just keep like that. You're almost done with half of the course, you can say. And the other modules are going to be really interesting, believe me. Once you guys do CNS with me, you guys are gonna be really happy in there. Okay. That's going to be like really easy modules. So just stay on track. I'm so proud of you guys. Just stay consistent like that. And one thing, I'm seeing very little activity in that Discord, and that's not good, right? You guys should be there as well. Okay. Thank you so much. Thank you, and have a nice day.